Hi friends, in today's video we're going to talk about pulmonary tuberculosis, and if you like this video make sure to give it a thumbs up and subscribe to my channel. I create new videos every week for nursing students, pre-nursing students, and nurses. Also make sure to check out all the free resources down below as well as the NCLEX study guide. So let's get into it. So what is pulmonary tuberculosis? It's an acute or chronic infection caused by Mycobacterium tuberculosis. It's characterized by pulmonary infiltrates, formation of granulomas with causation, fibrosis, and cavitation. Tuberculosis is an infectious disease that primarily affects the lungs. It can be transmitted to other parts of the body such as the meninges, kidneys, bones, and lymph nodes. And the primary agent is M. tuberculosis, is an acid-fast aerobic rod that grows slowly and is sensitive to heat and ultraviolet light. So the pathophysiology of tuberculosis is first inhalation. It begins when a susceptible person inhales the myocardobacteria and becomes infected. Then transmission. It is transmitted through the airways to the alveoli and is also transported through the lymph system and the bloodstream to other parts of the body. And the body's immune system responds by initiating an inflammatory reaction, and phagocytes engulf many of the bacteria, and TB-specific lymphocytes lyse the bacilli and normal tissue. And protection, so granulomas, new tissue masses of live and dead bacilli, are surrounded by macrophages, which form a protective wall. There's also Ghon's tubercle, and these are transformed to a fibrosis tissue mass, the central portion of which is called a Ghon tubercle. And then there's scarring, so the bacteria and macrophages turn into a mass that may become calcified and form a cholangious scar. Then there's also dormancy, so at this point the bacteria becomes dormant and there's no further progression of active disease. But there's also activation, so after initial exposure and infection, active disease may develop because of a compromised or inadequate immune system response. All right, so let's look at a pathophysiology diagram. So this is enough. So this is a nice pathophysiology diagram. I really like these diagrams because it gives you a lot of information on one compact area. So as you can see, we have airborne droplets containing the tuberculous bacteria enter the airway. Airflow and lung anatomy favors deposition of bacilli in the mid-lung zone. The alveolar macrophages then engulf this, and then it invades intracellular destruction via complex mechanisms. Macrophages engulf it, and there is pro-inflammatory cytokines. So that was kind of all the stuff we just went over. We can also see intracellular lysosome enzymes are released, which digest and destroy the bacilli, and tuberculosis infection is cleared from the body when that happens, which comes to one of the signs and symptoms we'll see, which is a sputum culture and smear, comes to one of the labs we will use, so sputum culture and smear. We can also see that if we come back to the pro-inflammatory cytokines, that will lead to infected macrophages travel to the thoracic lymph nodes. We will see activation of the macrophages lead to cell death, and the bacteria goes into the lymph system and spreads to other regions of the body, and that's when we will see the complication of extrapulmonary tuberculosis. There's also recruited macrophages phagocytose extracellular bacilli and become infected. The macrophages form granulomas, which comes to that Ghon focus viable, which is what you'll see on a chest x-ray. There's also recruited dendritic cells. So there's all these. This goes a little bit more in depth. You don't need to know all of these different cells that happen, but it's important to at least know the basic pathophysiology at the top, which is what we went over on the last slide. Also to know these signs, symptoms, and lab findings, so everything in the green, and the complications, so everything in the red. And you can see why certain processes lead to certain signs and symptoms. So you can see there's fevers, night sweats, weight loss, chronic cough. All right, we'll keep going. A lot of information. All right, so this is just an example of somebody with tuberculosis. So they may have a chronic cough with blood-containing mucus. That's really one of the major signs. And you can see the infected lung will be infected with that mycobacteria tuberculosis. So there's different classifications of tuberculosis. So class 0, there is no exposure or no infection. Class 1, there is an exposure but no evidence of an infection. Class 2, there is latent infection but no disease. Class 3, there is a disease and is clinically active. Class 4, there is a disease but not clinically active. In Class 5, there is suspected disease but the diagnosis is pending. So, causes of tuberculosis is close contact with someone who has TB, a low immunity, so if someone is immunocompromised, like those with HIV, cancer, or organ transplants, they are at an increased risk. Individuals with substance abuse, specifically IV injection drug use, and alcoholics have a greater chance of acquiring tuberculosis. Inadequate health care, so someone who might be homeless or poor, and even minorities can have a higher chance of developing TB. Immigration from countries with a high prevalence of TB, and anywhere with overcrowding. So if someone is living in an overcrowded area, this can increase the spread of infection. So clinical manifestations of TB include nonspecific symptoms, which can be fatigue, weakness, anorexia, weight loss, night sweats, and low-grade fever. And usually a fever and night sweats are a trademark sign of tuberculosis. They'll have a cough with mucus and blood, hemoptysis, which blood in saliva is common with TB patients, and chest pain. So they may complain of chest pain or discomfort. So prevention. So identification and treatment is important. Early identification of a person with active TB so we can get them on the correct medications. Prevention of the spread of the infection, because it is a control methods by reduction of contamination in indoor air, and surveillance. So maintaining surveillance for TB infection among healthcare workers with routine periodic tuberculin skin testing. Complications include respiratory failure, which is one of the most common complications. These patients can also get a pneumothorax when tuberculosis is not treated properly, and they can also have pneumonia, which is one of the most fatal complications of tuberculosis, as it causes infection all over the lungs. So our assessment as the nurse and for this patient is going to include a sputum culture, also a Zine-Nielsen, which is an acid-fast stain applied to a smear of bodily fluids, and this is a test they use for TB. There's also skin tests known as a PPD, or old tuberculin, which is administered by an intradermal injection. Positive reaction has an area of indentation 10 millimeters or greater, occurring 48 to 72 hours after the intradermal injection. It indicates that there was a past infection in the presence of antibodies, but is not necessarily indicative of an active disease. There are some factors that are associated with a decreased response to the tuberculin intradermal skin test, which includes an underlying viral or bacterial infection, malnutrition, lymphadenopathy, an overwhelming TB infection, insufficient antigen injection. Significant reaction in a patient who is clinically ill means that the active TB cannot be dismissed as a diagnostic possibility. A significant reaction in a healthy person usually signifies dormant TB or an infection caused by a different mycobacterium. There's also enzyme-linked immunosorbent assay, also called an ELSA, or a Western blot, and this can reveal the presence of an HIV infection. So we may want to know that for patients that have TB if they also have HIV. You can also look at a chest x-ray, which may show small patchy infiltrations of early lesions in the upper lung field. We may see calcium deposits of healed primary lesions or fluids of an effusion. There may be changes indicating more advanced TB, and they include cavitation, scar tissue, or fibrotic areas. We can use a CAT scan or MRI to determine the degree of lung damage or to confirm a difficult diagnosis. We can use a bronchoscope, which will show us inflammation and altered lung tissue. If an individual is unable to give a sputum sample, they may also use this to get a sample of sputum. We may use a histologic or tissue culture. We may look at a needle biopsy of the lungs. We can look at electrolytes, which may be abnormal depending on the location and severity of the infection. We can look at arterial blood gases, which can be abnormal depending on the severity of the disease. We can look at pulmonary function studies because decreased vital capacity, increased dead space, increased ratio of residual air to lung capacity, and decreased oxygen saturation are secondary to fibrosis or infiltration, loss of lung tissue, and pleural disease, which can all be found in extensive chronic pulmonary TB. We can look at histologic or tissue cultures. And yep, that is it. To the next one. So, medical management. The first line treatment of TB is isoniazid, which is also known as INH, and rifampin, which is also known as RIF, ethambutol, which is also known as EMB, and pyrazinamide. So for active TB, the recommended dosing includes the administration of all 4 of these drugs daily for 2 months, followed by 4 months of isoniazid and rifampin. For latent TB, it's usually treated daily for 9 months. In treatment guidelines, so they recommend for newly diagnosed cases of pulmonary TB to have an initial treatment phase and a continuation phase. So for the initial phase will consist of multiple medication regimen of INH, rifampin, pyrazinamide, and ethambutol, and lasts for 8 weeks. The continuation phase of the treatment includes INH and rifampin, or INH and rifampicin, and lasts for an additional 4 to 7 months. A prophylactic isoniazid treatment involves taking a daily dose for 6 to 12 months. And there's also direct observation therapy, which may be selected if an assigned caregiver directly observes the administration of the drug. All right, so here are those medications again. So isoniazid, also known as INH, is a bacteriocide agent that is used as a prophylaxis for neuritis and has side effects of peripheral neuritis, hepatic enzyme elevation, hepatitis, and hypersensitivity. There's also rifampin, which is a bactericidal agent that turns the urine and other body secretions into an orange or red. So that's an important thing to note. You may get a question about that. And it has common side effects of hepatitis, febrile reactions, purpura, nausea, and vomiting. Pyrazide is a bactericidal agent which increases the uric acid in the blood and has common side effects of hyperuricemia, hepatotoxicity, skin reaction, and GI distress. And ethambutol, also known as myambutol, is a bacteriostatic agent that should be used with caution with renal disease and has common side effects of optic neuritis and skin rash. So our nursing assessment should include getting a complete history of the past and present medical conditions for the patient. We should also be looking at a physical examination. So sometimes TB patients lose weight dramatically and show the loss in physical appearance. So these are just some nursing diagnoses that we can use for TB. So risk of infection related to inadequate primary defense and lowered resistance. So that'd be anyone who's immunocompromised. Ineffective airway clearance related to thick, viscous, or blood secretions. Risk for impaired gas exchange related to decrease in effective lung surface. Activity intolerance related to imbalance between oxygen supply and demand. Imbalanced nutrition less than body requirements related to inability to ingest adequate nutrients. And our nursing care planning and goals can include promote airway clearance, adhere to treatment regimen, promote activity and adequate nutrition, and prevent spread of tuberculosis infection. So our nursing interventions, we want to promote airway clearance. We should instruct the patient about correct positioning to facilitate drainage and increase fluid intake to promote systemic hydration. We want to adhere to the treatment regimen and teach the patient that TB is a communicable disease and taking medications is the most effective means to prevent transmission. We want to promote activity and adequate nutrition. So we're going to plan a progressive activity schedule that focuses on increasing activity tolerance and muscle strength, and a nutrition plan that allows for small, frequent meals. We want to prevent the spread of tuberculosis infection, so the nurse should instruct the patient about hygienic measures, including mouth care, covering the mouth and nose when coughing and sneezing, and proper disposal of tissues and hand washing. We also want to look at acid-fast bacillus isolation. So we will initiate these immediately, which includes the use of a private room with negative pressure in relation to surrounding areas and a minimum of 6 air changes per hour. Disposal will place a covered trash can nearby or a linen bag at the side of the bed to dispose of tissues, and we're monitoring for adverse effects of medications. So our evaluation could include things like, and it's going to depend what our patient outcomes are. So promoting airway clearance, adhered to treatment regime, promoted activity and adequate nutrition, and prevented spread of tuberculosis infection. So our discharge and home care guidelines, so will include disposal of secretions, so cough and sneeze into tissues and dispose in a separate trash can. Isolation, wear a mask when going outside of the room. Activity and nutrition, reminding the patient to take a lot of rest and eat balanced meals. And adverse effects, we want to teach them about adverse effects to watch for with the medications. And our documentation guidelines will include recent or current antibiotic therapy, signs and symptoms of infection, breath sounds, presence and character of secretions, use of accessory muscle breathing, breath sounds, the characteristics of cough and sputum, respiratory rate, pulse ox, O2 sat vital signs, level of activity, causative and precipitating factors, any reports of difficulty or changes with these, calorie intake, individual cultural and religious restrictions, plan of care, teaching plan, responses to interventions, teaching and actions performed, attainment of progress towards desired outcomes, and modifications to plan of care and discharge needs. All right, so that is it for tuberculosis. If you guys enjoyed this video, make sure to give it a thumbs up and subscribe, and also check out all the free resources down below, as well as the NCLEX study guide. And I'll see you next time.